what we're involved with is not just doing the testing. We're also involved with the epidemiology. So where did it come from? What do we do about it? What's the patient population? And when you stratify the patients across the infectious disease side, you look at a couple of things. Pneumonia. Complex pneumonias are very severe. Most of those patients are in ICU or CCU. Secondarily, it can lead to sepsis, which is blood infection. And so your mortality and morbidity start to go up. So you need to be very definitive about how you approach that individual condition of that patient. If you put them on multiple antibiotics, those antibiotics may not be appropriate for that patient population because you're treating them empirically. And what we're doing now is we give them a cocktail of antibiotics because we really don't know what it is, so let's give them the shotgun approach. And I don't think that works anymore. We used to be able to treat a patient based on 85% this organism would respond to this antibiotic. But in today's environment, we have genetic drug resistance. The overuse of antibiotics has created a class of organisms that are highly drug resistant. And they're transferring these genes amongst one another. So that if, just like we're communicating, it's called quorum sensing, they'll communicate with one another and say, there's an antibiotic, I need this gene to have resistance. And within an hour, organisms will transfer genes to one another, they'll replicate it in their DNA. Now they become drug resistant. Now that's important to know from a pharmaceutical standpoint as well as from the physician's standpoint of how to diagnose that patient. You know, if you look at hospital-acquired infection, we classify it that way. We did a study with an organization up in Ohio. What was very interesting with it is their overall infection rate for non-tested patients dropped, which tells me that in the analysis we probably found the portal of entry for that infection into that hospital. It was through that population of patients we were testing, but we were testing them before they got into the hospital. So we eliminated isolation and we eliminated any readmissions of that patient population. So we were able to prevent, again, the infection prevention and control. We were able to prevent an event, and then we're able to control the environment so that there wasn't this cross-contamination of infection from one patient to another. And that's really the hospital-acquired infection side. So I think that what the government's going to look at now is, can we incentivize hospitals to come up with alternatives to be able to save more patients' lives and to also reduce the overall rate of infection within the hospitals classified as hospital-acquired infection. If you look at reimbursement, the reimbursement is tied now to your infection rate. So the higher your infection rate, the less your reimbursement. There's another one, the classification, and it happens to be in this article, about catheter-induced bloodstream infections. And those are where you actually have a catheter for medication. I think now they're looking at changing those every 3 days, but if you don't, and you get a catheter-induced bloodstream infection, you lose 2% reimbursement from Medicare. That's another one where the government says you have to control your environment. That's not a prevention issue, it's a control issue. So we've got these issues now involved with hospitals on infection prevention and control, but I don't think we have the mechanism yet in place to be able to do the prevention and control. There are studies going on right now, and we're involved actively with those studies. And as a matter of fact, we've already submitted an abstract. We're going now into publication for it, and then we're going to roll out what we call our solution provider program. It's a solution that goes hand in hand with Partnership for Patients. Now what's interesting is we did not know about the Partnership for Patients at the time that we started to roll this program out. This comes out April 17th, and we had already been working on this since last year. So now all of a sudden this comes out, it's really timely. Because I think that with a Partnership for Patients, hospitals are going to be looking for alternatives. One of those alternatives may be the way we approach infectious disease. So it's a solution. It's not just one component. And when I say solution, what we look at is can we prevent the infection from coming in the hospital, especially for pre-surgical patients? If the patient is in isolation, can we test the patient to find out if they really have an infection? And if they don't, can we take them out of isolation? So that's another prevention issue. The third is that if a patient does have an infection, can we treat it? If the patient's only colonized, how do we treat it? Do we treat it systemically or do we treat it topically? So that all these issues now come up where you can either prevent or you can control the infection rate.